Okay, thank you, everybody. Hopefully you can hear me, and I will shout as loud as I can. So today I'm going to talk about some analysis we do in our organisation. So my name is Lisa Mumford. I'm head of organ and tissue donation and transplantation studies. So I oversee all of the studies that are undertaken in organ and tissue donation and transplantation. And today I'm going to give an overview of decision aiding tools for deceased donor offers. There we go. Okay, so just to give an outline, so why do we need decision aiding tools? I'm going to talk a bit about our risk communication tools that we set up. We have something called an aid memoir, which I'll talk through. We've got some other tools to help our transplant community, and then to give a summary. So why did we feel like we needed these? Well, there was lots and lots of press stories. So, for example, the Mail Online, heartbroken that a transplant patient who was given a kidney from a 25-day smoker faces a lifetime of dialysis. We've got somebody else in the press talking about gladly taking a smoker's lungs and the chance of or the risk of cancer from those. We had two patients that sadly died after being given a kidney transplant that were infected with a parasitic worm. And also we have transplants from HIV positive patients for both kidneys and liver. And this was a breakthrough. So it's about using risk safely in our patients. And then finally, a teenager, 19, who survived the liver transplant and then developed 6 different types of cancer from that. So again, talking about risk, being risk averse or cautious can really make a difference in transplantation, because we have far too many patients on our waiting list and not enough organs to help save the lives of these patients. But also we had the law that came in, Montgomery versus Lancashire, and this is where it progressed from being doctor-focused to patient-focused. So patients should now have more decision-making in their risk taking and their risk appetite. And as we know, it's moved significantly away from the idea of a paternalistic doctor. So the law stated that the patient should be autonomous and should be supported to make the best decisions so that they can make the decisions based on risk. But the problem is we do have a problem with risk literacy in this country. And for example, when you say to somebody there is a 30% chance of rain tomorrow, many people don't understand what that means. Does that mean there's a 30% chance in the United Kingdom? Does that mean that there's a 30% of the day tomorrow will rain? Or is it that 30% likelihood that it will rain tomorrow in your location? Many people wouldn't understand how to describe that. So that's why it makes it more complicated, and why we need to make these decision aiding tools to help our patients. So we have something here called our UK Kidney Donor Risk Index, and this describes how high risk a kidney is for implantation into a patient. And what we can see from here, so we've got the light blue bars show our proportion that we determine high risk, and the blue bars at the bottom, the dark blue bars, are those that we determine standard risk. And over time, we can see that as we're seeing more older donors donate their kidneys, we're seeing more donors with history of hypertension, more donors that have a higher BMI. We're starting to see centres transplant more of those higher risk kidneys into patients. And the reason they're determined higher risk is because the outcomes of these kidneys have a slightly poorer survival. And so there is a balance there as to whether we take that risk. So you may not put these higher risk kidneys into younger patients where we maybe require longer survival because they're likely to require a second transplant. Whereas in our slightly older patients who maybe only need 15 years transplant survival, these kidneys will really help and maintain their life. So we can also look at this risk by centre. And we can see here from this chart, so this is something we report on often, is the risk appetite across our centres in the UK. So we can see here from, for example, Nottingham, and we've got Cardiff and Coventry. They have a much lower risk appetite than maybe some of our other centres like Bristol, Liverpool, and also Oxford. Something else we report, so hopefully many of you know the use of a funnel plot, but we have a funnel plot here. So we have our national average, and this is displayed with our black line. And what this shows is that around 50% of all kidney offers to transplant centres are declined. And what that means is that we're then having to make multiple offers to different centres. It takes a long time. And finally, one centre may accept it and the offer will function really well, or the kidney will function really well. And these dots on the chart represent all our different centres. And you can see there that some centres are above the red line and have much lower risk appetite, so decline a lot more kidneys, whereas other centres below the green line, they have a much higher risk appetite and accept more offers for transplants. And we know that this risk decline rate leads directly to waiting time to transplant. So if you are registered at a centre with a low offer decline rate, so a higher risk appetite, their waiting times are much shorter and patients get that life-saving transplant quicker. So moving on to the development of our risk communication tools. So we just had lots of discussions within the transplant community about why risk and consent are really important to both our clinicians and our patients. And we definitely identified scope for improvement in how we communicate risk and consent. So this was framed by national data. We wanted to make sure this was an informed decision. It must be relevant to our patients, and also we wanted to facilitate that interaction between patient and clinician, so to try and remove that barrier of understanding. So we had general principles. So when talking or when taking consent, clinicians must take reasonable care to ensure that the patient is very aware of the material risks involved and any reasonable alternative or variants to treatments. And we do currently have lots of online resource information on our website for patients. We've produced lots and lots of reports, but actually trying to look through that data as a patient is really difficult because we have maybe one report with 168 pages, and trying to work your way through that, it requires a good understanding of data, and not all of our patients have that. So we also developed alongside this risk communication tool a website for our patients to try and give a lot more information, so break down that information. So we have that split by organ, and it gives high level information and then more detail when patients want it. So it starts with things like the benefits and risks, how long you might wait for a kidney, what you might expect to see at the transplant centre. So we had to start this as a project proposal. Okay, so what did we want to know? So we wanted to know what was the expected survival of a patient on the transplant list, how long could they expect to wait for an organ, and what are their chances of just being removed from the waiting list? And then finally, once they get that kidney, what is their expected post-transplant survival? Other things that we would like to know, but we couldn't quite analyse in the time frame that we had, were should the patient actually be listed for a transplant? Were there other better alternatives? So for a kidney transplant, for example, you can have renal replacement therapies. So you can go on dialysis, and you could live on dialysis for a long time, but does that give you the right quality of life? So those are the questions that we would like to ask. Also, another question is, should I accept this organ? So balancing that risk about whether should you take it, should you wait on the list and wait for another organ offer? That's something that we're currently analysing now. And if you do say no to that organ, how long then might you expect to wait if you say no? And what's the survival benefit? So I'm going to talk through our kidney risk communication tools. So this is an online personalized calculator that we developed to help communicate risk and benefit about transplantation for our patients. And it helps visualize the possible outcomes, and we try and do it in a way that is accessible for all. So it was designed to be used by clinicians with their patients. So we didn't want patients to go off and use this tool on their own. Again, patients reading data through a tool, they may misunderstand what the tool is showing. And so again, we have heavy warnings on this that says, please use this in consultation with your clinician. Because numbers of paediatric kidney transplants in the UK are really, really small, we didn't have the data behind this to back up the analysis. And so we only based this on adult patients. And this is a communication tool, so it shouldn't be used to make decisions in isolation. This is to advise and to aid decision-making. There are a lot more things around this that can help to make the decision and the process. So we built this in our statistics team. So we are a team of 25 statisticians within NHS Blood and Transport, and we undertake all kinds of analysis to do with transplantation, to do with blood analysis, stem cells, and we also have a clinical trials unit. But we also took evidence and help in developing this for patient use with the Winton Centre for Risk and Evidence Communication. So the methodology that we used was a numerical approximation algorithm for cause-specific Cox proportional hazards models. So in terms of, we had multiple Cox proportional hazards models. We can't, so because we're looking at the waiting list where we have multiple different outcomes, we've had to use this process. We tried a number of different techniques, but we always found that putting the results together, it became above 100. And so we worked together and used this numerical approach. So for the waiting list, we have the time along the bottom, so the years post registration, how many percentage of patients up the left axis, and then the curves for each of the possible outcomes on the waiting list. So you can see there, all patients start alive on the waiting list, the black line, at day 0. And then after 5 years, you would hope that the majority of them leave the waiting list. And then in that red line, you can see that around 2 years post-registration, about 58% of our patients receive a transplant. Then for post-transplant survival, we used just a Cox proportional hazards model. So we are very lucky within NHS Blood and Transport that we collect a wealth of data on our transplant patients' journey. So we collect data on donors, on patients joining the waiting list, all the information about the transplant that's undertaken, and then all follow-up until that graft has failed. So for our waiting time to transplant model, we used adult first kidney-only registrations. We looked at data outcome up to 5 years post-listing. And then unfortunately, we made a change to our kidney offering scheme in 2019. So at the moment, we're not taking account of that. But hopefully this scheme was trying to improve waiting time to transplant. So as we get more data, we can update these models. And then for our post-transplant survival, again, we used adult first donor kidney-only transplants. Again, we looked at 5-year outcome, and we're looking at just deceased donors. So we've got, in one model, and living donors in another model. So we treat them separately because they have different outcomes. So this is what our tool looks like. We used SAS visual analytics software to create this tool. So underpinning this is those statistical models. So when a clinician comes onto this tool, first of all, they are able to pick their transplant centre. So we have in kidney 24 transplant centres in the UK. So it's very tailored for that specific unit. Then they input the factors that we found to significantly affect their waiting time on the transplant list. So we have age, for example, their matchability score, which for those outside of transplantation will have no idea what that is, but it's basically a determination on how well matched a kidney is for the recipient and the donor. And if you have an easy score, it means that you are more easy to find a donor for to match. And if you have a difficult score, it means that you're probably not going to find a donor maybe you might have to wait 7 years for a transplant because there are so few that will match with you. But what we do have is information buttons on the tool. So for people that are unfamiliar with these terms, we then, you press that and a pop-up comes up explaining what that is. And then once you've entered all your information about your characteristics, you can then look at the results. And we present these results in a number of different ways because patients, again, that all patients and all people are different. You may be more interested in seeing information as a bar chart. So for example, we can look here that 3 years after listing, we can see that 25% of patients are still waiting for a transplant, 62% of patients have been transplanted, and then we've got just over 10% have been removed or have died on the waiting list. Now, not everybody can see that as a bar chart, so we also present this as a line chart for people to view that find it easier to view it this way. We also present it as a table. Again, more people may be used to seeing information that way. And then finally, we can present it as text. So for example, you would click on the numbers post listing. So here, 3 again, and then you can see that 25 people out of 100 will still be waiting on the transplant list. So it just makes it easier and breaks down that information for people to then have those informed discussions with their clinicians. So we also, if you just want to look at the bar chart, we can make that bigger in the tool just to have that, and then they can print that, take that home and discuss with their families. And then this is the deceased donor graft outcome tab. So again, we have donor patient survival and graft survival. We've got our center at the top and then the characteristics. But in this yellow box is characteristics about the donor. Now, when the patient joins the waiting list, they're not going to know which donor they have. And so we have selected the average donor in these boxes. But what you could do is you can change the donor characteristics to see how that may affect your different risk. So for example, if the donor had hypertension, you'd click yes and see how that changes your graft survival outcome based on your characteristics. And again, we produce this as bar chart, line chart, etc. So in summary for the tools, these were developed to communicate clinically relevant statistical information that influences patient and graft outcomes. And hopefully it does help patients understand that data in more detail by breaking it down. And clinicians, when we have talked to them, they have given us positive feedback. Unfortunately, the SAS Visual Analytics tool is a little bit slow, so we're looking to develop these in our Shiny to make it a bit more interactive and intuitive to use. But this was something that we had to start with. So all of our tools are open access, although they have the warnings to say, please use this in consultation with your clinician. They are available on the website, so everybody can go on and have a play and see what they look like. And we update our parameter estimates every year. So as things change in the community, we can see that coming through in the tools. And then the full model is reevaluated every 5 years to see if any new factors are influencing the outcome. So now I'm going to move completely away from the risk communication tool and look at another tool, which is our aid memoir. So this is a new online tool, and it's less about statistical analysis, but again, it more is about how we can display information in a condensed way to make it more easy to access and to make decisions. So, so this is designed to assist clinicians when they're assessing the use of organs, specifically those that are high risk. And it was hoped to replace a very heavy document and putting this all into one tool. It makes clinicians are able to go online, press a few buttons, and hopefully make a decision really quickly. So we have a deceased donor that becomes available. They're then characterized by our specialist nurses for organ donation. Then we have them register them in the system and our hub. So our specialist team offer out those organs to a transplant centre on behalf of a particular patient. So they are named patient offers, and then they have to evaluate whether they want to accept that organ for that particular patient. So this is the guidance, and I'm going to just go through it very quickly because it's very boring and very long. But as you can see, there was an awful lot of documentation that they had to look through in the past to say, okay, should I take this organ? Is it risky? Is it safe? So what we essentially did was created this quick reference guide to look about donors with infection, donors with a history of malignancy, and donors with potentially transmissible diseases. So we don't have an exhaustive list, but this tool can be updated so that when new transmissible diseases become notified, we can add them to the tool. Again, like I say, these are decision aiding tools. So the ultimate decision on whether a clinician uses the organ is down to him or her, and whether they can use this to help them. So they have the statistical background knowledge. So again, this tool is available on our website. Again, it's not going to be much use to anybody in this audience, because I very much doubt you accept kidney offers for patients. But you can go on and you have the disease type, so you can select the option. So let's say that the kidney has a malignancy. Then when you press the malignancy, it comes up with other options. So for example, other solid malignancies in a kidney, it's renal cell carcinoma that's less than 4 centimeters. It then tells you whether this is acceptable for transplantation. So in this case, it's saying, yes, it is acceptable for transplantation, it gives you the 3 categories. So whether it's exceptional, urgent, or routine. So you enter those data, this gives you the outcome. Like I said, it's got lots of warning. So in summary, for those tools, they were developed to help clinicians to make decisions when using organs for transplant. It's designed as a quick reference guide rather than the big, heavy documentation. But again, ultimate decision rests with the clinician. And again, like I said, they're on the website and they are uploaded or updated with our SABTO guidance every year. And then finally, very briefly, just looking at other tools available. So we have something called a calculated reaction frequency tool. So this tells you how difficult to match a patient is. We have a living donor kidney incompatible pairs tool. So this tells, we have a system in the UK called our UK Living Kidney Sharing Scheme. And this is where, say, a husband wants to donate to their wife, but they're not compatible. So they go into a scheme as a pair, and if they match with another pair, then the husband can donate to the other person's wife, and the husband of that wife can donate to his wife, and so we have a cross. So we have a tool to say how likely your particular pair is to match in this scheme. We have that matchability calculator, so the matchability that I talked about, whether you're easy, difficult, moderate to match, this can calculate how you are in the scheme. And UKELD is a form of calculating how severe your liver disease is, so a patient can go on. So just an example of the tools here. So just to summarize all that information then, so tools are developed for clinical or operational need to give guidance when making decisions. And we found them really, really useful in the transplant setting. They hopefully help to communicate risk and benefits of transplantation to patients in an easy to understand format through those visualizations, and to try and to convert really complex statistical analysis and underpinning into a way that patients can understand. Like I said, the SABTO memoir is a quick reference, and it's converting that heavy text document into an easy to use format. And just again to note that all the tools are on our website. We are hoping to develop more tools like this. So I mentioned previously, we're looking at whether a patient should accept the organ or not. We're looking at collecting more data on things like time to dialysis. So we're working with our counterpart organisation, the UK Renal Registry, to try and build this information. So again, sharing data between organisations helps to inform decision making. And we have feedback on our website for all of our clinicians and patients to hopefully help us update and develop these tools to make it much more easier for patients to use. So I just want to thank all of our transplant staff and our nurses and everybody that works in collecting this data, because we wouldn't be able to put all this information together. So we have our project team, our statisticians, the Winton Centre and the Aid Memoir project team. So that is all I have to share with you today on this topic.